Hi, everyone. Welcome to another Monty Heart lecture. It's a real honor to have today Dr. Bruno Lima from Vanderbilt University, who will be speaking about transforming heart transplant surveillance and the use of multimodality imaging. Dr. Bruno Becerra Lima is an assistant professor of medicine and radiology and associate director of the Advanced Cardiac Imaging Program in the Division of Cardiology at Vanderbilt University. Well, he also serves as a principal investigator of the VIDAR CMR program and architect of the Vanderbilt Multimodality Cardiac Transplant Registry. He earned his MD and PhD in Brazil. Then he completed internal medicine residency at the University of Pittsburgh Medical Center and cardiovascular disease fellowship at Emory University Hospital. After that, he went to Brigham and Women's Hospital in Harvard, where he completed an advanced cardiac imaging fellowship, where he was also named the chief fellow. He's board certified in internal medicine, cardiovascular disease, and multiple cardiac imaging modalities. His research focuses on the brain-heart axis, integrating advanced cardiac imaging, genomics, and pharmacology, including the development of a multiparametric stress CMR for the detection of cardiac allograft vasculopathy. And even an early career as he is, he has already over 70 peer-reviewed publications and book chapters. So a rising star for sure. Thank you so much for joining us, Bruno.
Yeah, thank you so much, Leandro. And it's a pleasure talking to this amazing audience, here in a place where I have a lot of esteemed friends, like yourself, Aldo, many other rising stars as well. So I have no relevant conflicts related to this talk. And before getting to the imaging part, I want to briefly set the stage. And at Vanderbilt, our heart transplant program has grown substantially over the past few years. We now perform more than 200 heart transplants per year. And that volume is exciting, but it also creates a lot of pressure in our health system. And this creates an important unmet clinical need for surveillance strategies that are safer, scalable, sustainable, not just for individual patients, but also for the program. And here are the four main take-home points that I would like to leave with you today. So first is how to recognize early imaging markers for rejection in cardiac allograft vasculopathy. Second is how to choose the right imaging modality based on biology of the disease and the timing of the transplant. Third is how we combine echocardiography, cardiac MRI, PET, coronary CTA to reduce routine invasive testing. And finally, is how to apply all of these in real-world patients using practical and clinically realistic approach. Okay, so despite all of the testing we do, surveillance still fails more often than we would like. And the main reason is because immune-mediated injury, it evolves over time, in which we have acute rejection early on, especially during the first year or so. There's a mixed risk period between the first and third year. And after the third year, cardiac allograft vasculopathy becomes dominant. So patients, the other thing is that patients after heart transplants, they have a denervated heart. So they feel well, they don't have any chest pain, they don't have any warning symptoms. And so our traditional tools, they have also important blind spots that I'm gonna talk about now. So the reason why traditional surveillance is failing is the next question is why? And the issue is not the effort, but it's the tools that we consider gold standard. So for instance, coronary angiography give us a lumen-only view and completely misses diffuse or microvascular disease. It also carries contrast and vascular risk, especially in patients we follow for decades and need to have repeated CATs over time. Endomyocardial biopsy similarly has its own problems. It's invasive. We can have an issue with sampling error. So we might be misled in patients that might have rejection, but we might be sampling an area that has normal myocardium. And also the complication rates are not trivial. And many of the patients, they develop significant tricuspid regurgitation, up to 30% after repeated biopsies over years. And these tests are useful, but again, they're never designed to be lifelong screening tools. So this brings us to a necessary paradigm shift. On the left, we have the traditional surveillance model, in which, again, the patient feels well, we do schedule biopsies, we schedule the angiograms, we escalate only once advanced disease is detected. And that approach is reactive, again, very invasive, and it's biology blind. On the right side is what we're moving toward, which is a risk-adapted multimodal strategy. We start with the clinical context and the time from transplant, and we establish a non-invasive baseline. We then use advanced imaging selectively, and invasive testing becomes targeted, not routine. And this is more personalized, quantitative, and that's biology driven. And the key concept is that biology determines what imaging can see. So on acute rejection, on the right side, it is primarily a myocardial process. It involves inflammation, it involves edema, and it's kind of a patchy tissue injury. And these changes affect also a few issues with the function of the heart, as it impairs relaxation, the formation very early on, and long before we see a drop in the ejection fraction. On the other hand, cardiac allograft vasculopathy is completely different. It's a concentric diffuse, and it involves both epicardial vessels and the microvasculature. And the dominant signal is impaired coronary flow or myocardial flow, and it often results in balanced ischemia. And if you use the wrong test, for the wrong biology, as we're, have been doing for many years, you're going to miss disease. And this is why one modality or one test, is not enough. And this slide highlights how we currently define CV. This is the International Society of Heart-Lung Transplant grading system, and it's based largely on angiographic findings. But angiography, it classifies disease late, and by the time you see focal stenosis or left main involvement, diffuse disease has often been present for years. And functional upgrading based on graft dysfunction helps, but again, it reflects advanced biology. So angiography is important, but it is not like an early detection tool by any means. In each imaging modality, when we talk about non-invasive options, they give a different window into the disease. So echo, for instance, is excellent for function, deformation. It is ideal for screening in serial surveillance because there's no radiation, very easy, very widespread. Cardiac MRI allows tissue characterization, quantitative perfusion. It is particularly powerful for detecting rejection and also diffuse CAV, as you're going to see later in the talk. And PET imaging measures absolute myocardial blood flow and flow reserve. This gives us a functional assessment of CAV and strong prognostic information. In coronary CT angiography, again, shows anatomy and plaque burden. We are also moving in, of course, to having fractional flow reserve, CT-based fractional flow reserve. It works well as a rule-out tool and for anatomical classification. So the strength here, again, comes from the integration among, each of these modalities, not a competition between them. So let me walk through the first case. This is a 52-year-old man. He's 3 months after heart transplant. Patient is completely asymptomatic. This is just a routine surveillance. And we start as the most of us do, with transthoracic echocardiography. As we can see here, the patient has moderate LVH. And what we can also see is that the ejection fraction is preserved at 55% using symptoms by plane method. But the global longitudinal strain has declined from minus 18% at baseline to minus 13%. There's also moderate left ventricular hypertrophy, as I mentioned, and this is like a classic teaching point. So the EF stays normal despite significant inflammation. Again, cannot stress enough, these patients are denervated, they don't have any symptoms, they're not going to have any symptoms. So the strain decline is often late, but it's an important marker of rejection. And echo, again, raises a flag, but it does not give us the full answer. When you look more deeply into the literature, we can see that strain, for instance, clearly outperforms ejection fraction. Having a few other markers like increase in wall thickness compared to baseline also can indicate rejection, as we have edema. Also, pericardial effusion can be another marker, although it's something that might be very common, especially in the early months, just as a post-surgical change. But again, GLS, very sensitive, negative predictive value is very high, but it's not specific for etiology. Multiple things, can give a decrease, in global longitudinal strain. Other than having rejection per se, there might be, CV or, other processes. So that's the main issue of that modality. So then it comes a point, so what are we going to do next, here? We have several options. You could go straight to biopsy. You could consider molecular testing. You could move to advanced imaging. Again, in this case here, at least, in Vanderbilt, we're going to do a cardiac MRI, although myocardial biopsy will be reasonable here as well. And this is the same patient, and his CMR shows clear abnormalities. As you can see, the native T1 is markedly elevated at 1100 milliseconds. Normal T1, for reference, should be less than 1030 milliseconds in a 1.5 Tesla scanner. Also, T2 is markedly elevated at 61 milliseconds. And the normal reference here should be less than 55 milliseconds. We also see the presence of LGE, especially in the septum here, and on a subepicardial type of pattern. And on the ECV, we see, especially like in the septum, we see like a regional increase, but the global increase is also high at 38%. The normal, again, is less than 31%, and this pattern is highly suggestive of active myocardial inflammation. And unlike biopsy, again, this reflects the entire myocardium. So then we proceeded with biopsy, and biopsy confirms moderate grade 2 rejection, and it shows those multiple foci of interstitial infiltrate and associated myocardial damage. And again, this is very important that CMR identify biology before the EF changed dramatically. Remember that we only had a fairly subtle decrease on GLS, right? And also the wall thickness was increased, although this is something that we typically see during the first 6 months after transplant, and that's something that tends to regress over time. But whenever we take a look at the literature, we look at the performance metrics, and a few things stand out. There's a very important meta-analysis, by the CDIS group at JACC Imaging on 2021 that show that LG alone is unreliable because it can happen, due to different reasons, not only active inflammation, but the patient might have had scar, from a previous episode of rejection, or might be, due to other issues that are not necessarily related to inflammation. So it has both like false positives and false negatives. On the other hand, T2 mapping is consistently is the one metric that shows the highest accuracy, as you can see here, at 0.92. Especially if we consider the cutoff of greater than 55 milliseconds. And that's where that number came from. But most importantly is if we combine everything, if we use like a multi-parametric approach, it outperforms any single marker. This is another interesting study. And here we see a stepwise increase in T1, T2, and ECV as we go from control to patients with progressive amounts of acute cellular rejection. So one of the things that is interesting here is that we have a normal ECV, normal T1, normal T2. On patients that had like an acute event, they have very high T2. Here you can see at 58 milliseconds, high T1, high ECV. Patients with prior acute rejection, the T2 will be normal here. And the ECV will also tend to be normal. But the T1, will be elevated, so this is that pattern that we typically see with, interstitial fibrosis, some scarring that we see not only like in transplant, but we see this typically in patients, for instance, with chronic high blood pressure. And that's like a very important slide, because these are like, the patterns, that you're going to see. And again, T2 stands out as a very important marker. If there is edema, there's a much higher chance, in this case, that the patient is going to have active inflammation. If it's just, T1, and also ECV is very important, in that context as well, differentiating from past interstitial fibrosis, type for something more acute. Okay, so the network question now is whether those works, in which we saw a lot of small observational studies to see if this is something that translates into clinical practice. And this is a landmark paper by a group in Australia that was led by Dr. Jabor and Chris Anthony, here, in which it consisted of two phases. First, they had a validation phase in which CMR parameters, they were compared directly to biopsy. And for clinically significant rejection, they found a cutoff of native T1 of about 1,030, similar to what we saw. And for T2 of 60, they show an excellent negative predictive value here whenever we combine both of these, approaching 99%, approaching 100%. So having that in mind, they went to the second part of the study, in which they randomized 40 patients into either a CMR guided screening for acute rejection versus an approach in which they were using biopsy, for screening. And they use that clinical algorithm on the CMR study arm. So if the patient had normal T1, T2, if everything was normal here, as you can see, less than 1,000 and T2 less than 57, they're just doing clinical management. If one of these, like T2, if it was elevated or T1 was elevated, they would do either biopsy, or they were going to do biopsy and they would do post steroids, cases in which they had more they had more inflammation, they had more abnormal numbers. And whenever we take a look at the results, the rates of grade 2R rejection, they were very similar between the groups. There's no difference here. Again, this was a non-inferiority trial. But something that is very important here is look at the testing burden. We only see 11 endomyocardial biopsies on the CMR group. Again, they did 238 CMR serial scans on these people. Only 11 biopsies. And on the myocardial biopsy group, they had 235 biopsies. So again, hundreds of biopsies were avoided in the CMR arm. And this is, again, much safer, more patient-centered. And another thing that is very important, especially for the insurance companies, is that there is an 80% reduction in costs. Fewer procedures, fewer complications, lower overall resource use. Again, this is a striking number. Although, again, this is a small study with only 40 patients that were randomizing. This is a very striking result. And on the editorial that followed that landmark paper wrote by Jin Feng from Utah, he proposes this new algorithm in which we start with CMR, and depending upon the parametric mapping numbers, we're going to decide if we're going to do biopsy or if you're going to consider other approaches here, either continue with CMR. We can use donor DNA testing as a surrogate, as well, which can be very helpful if we use together some of those biomarkers. And then, use biopsy for cases in which there's still some clinical uncertainty. But now we're going to shift the biology. This case is totally different. Now we're talking about a 6-year-old woman, 2.5 years post-transplant. She has mild exertional fatigue, and both EF is normal at 60%. And the strain is also normal at minus 19%. The patient ended up undergoing a stress echo, giving her symptoms, which was entirely normal, as you can see here. There's good augmentation. The patient reached 92% of maximum maximum heart rate. There's no regional motion abnormalities, no EKG changes. But again, is this reassuring enough? Does this exclude diffuse or microvascular disease? And if not, what's the next step, right? Again, we have a lot of options. We can go and do left heart catheterization. Again, right and left. We can do CT angiography, MRI, PET. In this case here, we're going to proceed with PET, okay? Although there might be other options, here that you can do, like, as MRI, as I'm going to detail later, right? But in this case, we did a PET. This is ammonia. She had pretty good function at rest, 60%. It increased to 64% with stress. On the perfusion images, no perfusion abnormalities here. But take a look at the myocardial blood flow and flow reserve. So here, the myocardial flow reserve is actually normal, it's 2.2. But look at the stress myocardial blood flow. It's very low, and it's diffusely elevated. We don't see much of a gradient, here. So this is a very interesting case. And using this PET algorithm, and I will detail to you a little later how we got here. So using this PET algorithm, we can see that the patient has normal perfusion, right? No perfusion abnormalities. The global peak myocardial blood flow is 1.3, so that's less than 1.7. The EF is normal. So this patient will be classified as CAV1 or PET CAV1, mild disease. And because of that, we just, defer invasive angiography, intensify immunosuppression. You can also use lipid-lowering optimization, as the patient also had some plaque on the calcium score scan. But this is very important. This is one of the earliest and most important observations in transplant imaging. On the left here, you see coronary flow reserve, measured by PET. And on the x-axis, this is the average maximal intimal thickness measured by IVUS. So what this shows is a clearly inverse relationship. So as intimal thickness increases, coronary flow reserve steadily declines. This happens before you see any focal stenosis on angiography. So PET, in this study from 1997, with the USLA group, it showed that PET detects this functional consequence of diffuse disease, while angiography, just looking at the anatomy, still looks normal, on this patient. So this study taught us that CAV is not a focal lumen-based disease. It is diffuse, it's concentric, it's physiological. And later, fast forward several years, this is 2014, that's Rob Beelan, Ben Shaw group, at Ottawa. They were taking a look at PET, rubidium PET, and pretty much it takes like a step further, from the previous test, because it takes a look at the prognosis. So on the left, we have stress PET images. One patient has preserved myocardial flow reserve. The other one has decreased flows, right? So on the right, you can see the survival curve. In the patients with reduced myocardial flow reserve, here, they have more than a fourfold increase in adverse events. And importantly, this is independent of angiography findings. So PET is not just diagnostic, it's prognostic, and tells us who is going to do poorly, even when the coronaries, they look okay. And here, this is work by some of my prior mentors, Dr. DiCarli, Dr. Dorbala, Paco Bravo, and here they go a little further, right? So we see what we call the PET-based CAV staging, as we talked before. On the left, we have event-free survival curves across PET-CAV categories that we saw earlier. For CAV0, one have excellent outcomes. Once you reach PET-CAV like 2 or 3, the outcomes, they really drop sharply, as you can see here. And on the right, it's the same message, right? But just more simply. So patients with PET-CAV, they have 2 or 3, with PET-CAV 2 or 3, they have significantly worse survival. And this is very important because PET allows us to stage CAV in a way that correlates with real clinical outcomes. It's not just anatomy, but, we have risk and we have a very stepwise, approach of doing this, right? So we start, and this is like, the proposed method that they validated, in which we start with the regional perfusion and global peak flows. And then if the flow is reduced, even with normal perfusion images, that suggests some mild, disease, some diffuse disease. If we have decrease in EF, that suggests CV, more severe, CV. On the other hand, if we have abnormal perfusion, even with a normal global peak stress flows, CV is going to be mild. Another thing that is very important here is that, while other studies, they talk about myocardial flow reserve, one of the problems that we see with transplant patients is that, again, denervated hearts, they have higher resting rates, they have higher resting flows. So because they have higher resting flows, the myocardial flow reserve, will tend to be lower. And on that study, Dr. DiCarli, Dr. Bravo, they also look at myocardial flow reserve and tends to be a little less predictive as using the peak myocardial blood flow, giving the higher resting flows, that we see, so that's a very important piece of information, here. And this is the final, slide for the nuclear piece. It also answers a very important question. This is by our colleagues at Yale, Attila Ferrer, Dr. Sinusas. And the main question here is what happened about the change if we have like a drop on serial imaging PET, if we have a drop, in CFR, what happens, to the patient? And what we see is that, if you have like a declining, CFR over time, it strongly predicted mortality and major adverse events. So this tells us that, again, CV is a progressive disease, and it's important, for the patients to have serial functional assessment that captures the progression, so it can compare apples to apples, and that adds like a different layer to our absolute numbers, that we're discussing before, right? But what about stress CMR? Again, stress CMR, it offers like a similar physiological insights. Again, quantitative perfusion continues to mature. One of the things, that we started doing, this is more than like over like a decade ago, is trying to put numbers on the perfusion, that we see, and we can achieve that, by just, drawing those regions of interest, in the myocardium and also the blood pool. And similar to PET, we can derive, those curves and calculate, what we call the myocardial perfusion reserve index, which again, it's not the same as myocardial flow reserve, but it's fairly similar. We cannot derive the absolute, flows from here, but we can definitely, get a relationship, that is similar. And this was shown like in 2016 by Erbo and colleagues, that if you use that technique, you can detect, cardiac allograft vasculopathy, which we know, it's diffuse, it's invisible. So we can see on the ROC curves, for myocardial perfusion reserve index, by CFR, it's about 0.75, here, the area under the curve. On the right, you see also strain, that it's another thing that we can on the post-processing, we can add that information as well, which also has some additive, value as well for detection of CV, in these patients. But if you are like a CMR reader, how daunting and laborious, and also sometimes might not be a great metric for you to see because of reproducibility. One of the issues that we do with CMR is that we start with stress, and after we give a stress agent, usually something like regadenoson, we revert that, giving aminophylline, and then we get resting flows. Although theoretically, the aminophylline would take care of the regadenoson, of the vasodilator, usually this effect lingers, for at least like 15, 20 minutes or so. So the patients, they tend to have kind of a higher, resting flows compared to the PET typical protocol, in which we do like rest first and then we do stress. This problem, we don't have that problem if we're doing adenosine, since adenosine has such a short half-life of about seconds. But still, there are several issues if you're doing this. Again, if I do it, and if a colleague of mine, is doing this, we might be like tracing this differently. So this creates rooms for a lot of inter-observer variability. And although this correlates relatively well with CFR, it's not great. But again, if you are like in a place that don't have some of the newer sequences we're going to discuss, that might be like a reasonable thing, to put numbers on what we see visually. So one thing that is also interesting, this is from 2000, this is a work by Jan Schwitter from Switzerland. And this is a very interesting study in which he used coronary sinus flow. He made those cuts, here at the coronary sinus. And we use phase contrast imaging so we could trace, the coronary sinus. So if we do this at rest, and then if we do this after stress, what we're going to see with the coronary sinus flow is that it's going to reflect the myocardial blood flow. And he compared that with PET. And you had a striking correlation between those two metrics, here. As you can see, over here, the correlation was in the order of like, above like 93, 95%, or so. So that's an interesting technique. Again, it's not easy, to do. But here at Vanderbilt, we have been doing this since 2019, and we have been scanning a lot of transplant patients, and using those techniques, although it hasn't been like, fully validated. And what I did was I took, those patients from 2019 when we started doing this. This is to roughly like 2024. We have about 400 patients. This is just like a preliminary analysis, of our data that is being considered, for review. And it was very similar to what we found with Marcelo Di Carli, in which after a threshold of 2, of a CFR of 2, or a stress myocardial blood flow of 1.8, interestingly here, the CFR was actually kind of a little bit of a better predicted compared to the stress myocardial flow. And also, we have native T1 and native T2, they also correlate with CV. Again, here we are comparing with cath, cath within like the first 30 days, or in patients that didn't have a cath within 30 days, patients that had 2 different caths before and after, and there's like no change in CV classification. So these are like, at least pretty good technique, for us to discriminate between severe CAV, from mild or no disease. And again, this is still like, evolving. We're still like, analyzing the data. But that's like some very interesting, point here. Again, during coronary sinus flow, not every program, they're gonna be able to do this consistently. There's some try and error, over there. There might be a little bit of inter-observer, variability, as you have to like, do like the tracings. But again, this is very, very promising, and we don't have to use anything fancy other than just like, regular phase contrast imaging. But now, we have those like fancy new quantitative perfusion sequences. This one in particular is from King's College London. This is by Amadeo Cerveri, and this image is actually from him and Ray Kwong, my prior mentor, at the Brigham. And what we do is we have the motion-corrected stress images, rest images. We can derive quantitative maps. We get like gadolinium images. There's like different ways of doing this. We can do like dual bolus, or we can do like dual sequence. This is something important because gadolinium, unlike PET, whenever you're giving like a PET tracer, the curve, the aortic pinpoint function curve, it simply goes all the way up, no limit. But for gadolinium, if it increases a lot, it can cause T2 star effect. So you're going to lose like the peak, and so the numbers for your coronary flow or myocardial flows, they're going to be inaccurate. But we solve that problem again early on, doing like dual sequence, dual bolus, which is a little laborious, hard to do. But now they have like those AI automated dual sequence, and they are extremely helpful because they give like the flows by segments. It's all automated, and the images they look beautiful, and also we can detect this much better with the flows, with the regional reduction flows, with those color maps, compared to just like the regular grayscale and whatnot. So here we have like this example of single vessel disease, and on the other hand we have triple vessel disease. That sometimes might be hard for you to tell, as you don't have like normal myocardium to compare with. And there's actually a fairly recent publication. This is by Jablonowski. This group, I believe it's Swedish, but they use a similar sequence. They use a sequence by Peter Kellman, which is now a Siemens product. And they use that sequence to study those patients with CAV, and they show that there's like this gradual decrease in CAV. There's a gradual decrease in myocardial perfusion reserve in patients with CAV. There's going to be higher in patients with no CAV. They're going to be a little lower, as the patients get more severe CAV. And using a cutoff of a myocardial perfusion reserve of less than 2.2, they have 100% sensitivity, although the specificity is 68%. But they have a great negative predictive value for patients with, for differentiating patients with severe disease and patients with mild or no disease. So let's go to our last case. So this case, it's 6-year post-transplant. This patient presents, it's a 58-year-old man. He presents with progressive short of breath, has CKD3, his GFR is 45, and he had some discordant functional testing. We did a coronary CTA, and it shows significant, some plaque burden, here, especially on the LAD. This is like, the automated roadmap, analysis, by HeartFlow. I don't see anything here, although like, the automated test is like, seeing something here. But we definitely see some severe, disease, here with this kind of non-calcified, plaque. With FFR, CT-based FFR, although, in this case, we could just, send the patient directly, to cath. But we can, confirm, the abrupt translational pressure drop here at the proximal LAD. It's pretty dramatic, and this is something, that we detected, with CT, right? And CT has several strengths and limitations. Some of the strengths is that very detailed anatomy, plaque burden. We have FFR CT. We have other factors. We can also measure like the pericoronary fat attenuation, and that's something that's related, with perivascular inflammation. Although there's a lot of data on patients with lupus and some other rheumatological conditions, there's very little data or no data on patients with transplant. There's a few limitations, contrast, patients with advanced CKD, especially like GFR less than 30. Microvascular disease you might, miss here, although there's some research, looking at the terminal, the terminal FFR, number, over here as a possible indicator for some microvascular disease. Another issue, has to do with, the fact that these patients, again, resting heart rates, they tend to be higher. So if you have a single source scanner, your temporal resolution is not going to be that great. So you might have some issues with motion degradation. There are some protocols we use here at Vanderbilt. We just use metoprolol, and it works really well. We have dual source scanners, here, and sometimes, we scan patients, with heart rates at 80, 90 or so. But we have very good quality images, despite that. The single source might be a problem, especially, for the RCA. And there's this really interesting work from this group, from Belmont, that was published at Circ Imaging last year, showing that CTA is accurate for CAV surveillance in patients with heart transplantation and can be considered actually preferred imaging modality for annual CAV surveillance if you compare this to invasive angiography with IVUS, right? So you can see that if we do the CCA anatomy morphology with FFRCT, we're going to have a sensitivity of 96%. Also, negative predictive value very high, at 88%. That's really good. And also, if we compare the same study, the contrast that the patients use to do ICA, IVUS, FFR, it's much higher than the amount of contrast that we use with CTA or CTA plus FFR. Again, FFR is just post-process, so we don't have to use anything else. And also the radiation is much lower, especially using, prospective gating, and so forth. So this is from a review that I published, recently, going over the CAV classification and what each imaging modality, shows, right? So again, for CAV, echo is not a great tool. Again, you're gonna see some systolic dysfunction. You can see decreasing of GLS, at advanced disease. But this is a late marker, so you want to go with either CMR, you want to go with PET. These are much better tools, for that. So the key takeaways here, again, one modality is never enough. I mean, I do everything. I read echoes and CTs and PETs and CMRs, and I love, imaging. So I'm biased, towards that, but one modality is never enough. Quantification, putting numbers like parametric mapping, flows, this really matters. Stage-aware imaging also improves outcomes. Don't just go blindly cathing and biopsying everyone. You can use imaging to avoid cathing everyone every year. And invasive testing, becomes selective, not routine in our more modern approach. A lot of what I did say today, it's just summarizing this contemporary review. Again, open source, you guys can go, to Jaha and look at that. Leandro was one of our co-authors here, and really glad, we're able to collaborate. Have to acknowledge our amazing group of, CMR group here, Chief Sean Hughes, Echo with Deepak, Nuclear with Marv Cronenberg, CCT with Jeff Carr, of course, Kelly Schlandorf, who leads, the Transplant. She's, again, she's a powerhouse. She's amazing. Bioinformatics, we have Queen Wells, getting all of this data. We have our cardiology imaging fellows, Gina Lazara, Luke Laws, and our residents. These are, they did a lot of work, in their free time that is very scarce. We have Chloe, who matching at UVA, Malek and Amu, they are applying this year. So if you're a program director, look over, these guys. And of course, my lifetime mentors, João Lima was my famous cousin, Ron Blanstein, Ray Kwong, Sharmila, Marcelo. And that's pretty much it.
Thank you so much, Bruno. This was amazing, and congrats in all the work you're doing. And thank you again for the invitation to collaborate with you in that great paper that I encourage people to read. So for everyone, please put your questions in the Q&A. We have there the code for CME. If you want to stop sharing, so
Yeah,
people
so let
can see
me,
you when you talk, and we can start going through the Q&A.
okay.
So Dr. Travin here, Mark Travin, our director of nuclear cardiology, has been also doing some work in this sort of patients. He says, we've been doing PETs for OHT patients for many years. I've been using a method proposed by the Ottawa group, combining stress, blood flow, myocardial flow reserve, and importantly, coronary vascular resistance, and measures the stress blood pressure over the stress blood flow to assess a potential microvascular disease not detected on conventional coronary angiography. He says, I found that in several cases, this predicts future detection of CAV on cath, perhaps by showing microvascular dysfunction. Any thoughts on this method by the Ottawa group?
Yeah. So Rob, Beelan's is again powerhouse, nuclear. Some of these metrics in which he uses, he calculates, coronary resistance. Again, we can derive that, from the flows. And I believe, these are definitely, useful tools. But what I've seen is that there's a lot of collinearity, between like, resistance and, like decreased flows, and whatnot. I believe that, again, I believe, this is interesting. However, I don't think it adds much, to what we already know in terms of, the flows. One thing that is very important is looking at relative flow reserve. This is what Marcelo Di Carli, calls the PET-FFR, taking a look at the gradient, between the base and the apical anterior walls and see if there's like, a gradient over there. On the case that we saw that I showed you, there's no gradient, no basal to apical gradient. But you might see like, some mild gradient in diffuse disease, or you can see like an abrupt gradient. And if you have like, this ratio, what he uses, in his practice, the Brigham is 0.8. So if it's less than 0.8, this translesional drop, in flow, that also indicates like a discrete, lesion. And I think, taking a look, at the regional variations, all of that, and I think it's more adds more, than just, adding some derived, metrics, that have a lot of, collinearity, with other, with myocardial flow reserve and myocardial stress myocardial flows.
Thank you very much. Very, very good answer. So Omar Said, that is also working with Dr. Travin on this, he says very informative lecture. And he has an important question. He says, at Vanderbilt, how are you protocolizing this multimodality approach in CAV screening versus then the treatment, like rapamycin initiation? Do you know that part?
Oh yeah, so this is it kind of goes a little bit beyond as I'm the imager, as I'm providing, the information. So again, I'll love, if Callie Schlindorf, was here, to help me, answer this question. But what I do know is that they definitely, if we detect, CV, or if we detect, lower flows on the CMR, or, PET, or even, we're also doing SPECT. We have like, DSPECT, as well. And this is just because of the sheer volume, and the patients, sometimes they have to like, wait. And we also open that option, as well, which is, with the help of also the Ottawa group, and with the help with Ron Schwartz. I didn't put any of our data here, but what we do after we see like, decreased flows or any concern, for CAV, is they're taking, to the cath lab, and they confirm. And after, it's confirmed, they have like, their own protocols, for CAV treatment, to just like, rapamycin and whatnot. But again, it kind of goes beyond of what I do as an imager.
That's great. And just so important, bringing this back, how important is to build these registries like what you're doing, and having ideally, multi-site registries, like there's now for refined PET, refined SPEC, but it's so much needed for transplant as well. I have a question about the MRI. Are you using feature tracking? Have you found that useful with a strain by MRI?
Yeah, so I haven't been using a lot of strain, with MRI. We are mainly, using, flows. Sometimes I do like in the post processing, in a few cases with, patients with thick walls. They have, let's say, some marginally, increased ECVs, and I sometimes I add, strain post processing, to illustrate, better, and show like either like a diffuse pattern or like a apical-sparing pattern or something like that. But I don't typically use that, for rejection or any of that. And if we use it's like sparingly, just to add some more information. But usually we base everything on parametric mapping, and the flows. These are like the main, and the function, of course.
And the flows in general from PET, you prefer over stress MR from what you were saying?
Yeah, the problem here is we use ammonia, and so we're kind of, limited in terms of our availability, for PET. And again, it's just an insane amount of patients, and they just adapted, to started using myocardial flows. First, derived from coronary sinus flows, and then we transitioned to KCL's sequence, perfusion sequence, and we are like, still validating that, and we're still doing the coronary sinus flows, and we're looking that it really correlates really well with the numbers that Amadeo Chiribiri sequence gives us. Although our CFR number, tends to be higher because we do the coronary sinus flow at rest, before, the stress phase. And so that's probably the explanation, because there's like, some regadenosine, lingering. Of course, it would be great if we were able, to do adenosine, but it's just like, it's so much harder, in terms of like the throughput, for the tax and everything, so we just, use adenosine and revert.
Thank you very much. And congrats again for the amazing outcomes and volume of the heart transplant, program that you're obviously part of. And we were talking with my boss, Mario Garcia, the other day about it, how impressive it is. So we have from Aldo a question. He says, "Hi, Bruno. This is an amazing and much needed lecture. Always nice to learn from you. Indeed, imaging is very useful in guiding care post-heart transplant." He asks, what patterns of LGE you typically see in rejection? Do you have any thresholds for abnormal T1, T2 in 1.5 TCMR? I think you showed something about that to differentiate mild versus significant elevation as suggested by the algorithm you presented.
Yeah, so this is that's a really important, question. Again, coming from Aldo. Aldo was one of my role models, as I was entering my fellowship training at the Brigham. He was leaving, and what we see with LGE is like, it's very typical for we to see, especially, patients who are older, or who are like far removed, from their transplants, and they're like 5 years or more, after transplant. We see a lot of, RV insertional point, and also on the septum, on the RV side of the septum. And that's something that it's usually like chronic. Doesn't necessarily mean that the patient, have rejection. It can be like, a previous rejection episode that is just scar, over there. The main differentiating factor here, and again, that's usually the pattern that we see. It's like, subepi can be diffuse, but it's typically more, in the apex. But like acute rejection, the main factor that we see is T2. Usually T2 goes way, way higher. Above 60, it's like pretty definitive. If it's between 50, 55, I'll just say like, upper normal, it's not very, striking. But between like 55 and 60, these are like some of the cases that you might want to talk to the referral person, and perhaps, consider biopsy. So T2, I find it to be much more important, than T1 or LGE. In ACV, it's also like a good, marker as well, although, again, the differentiating factor here, for inflammation, it's mostly, the presence of edema and also the graft dysfunction, as well.
They're repeating the CMR afterwards to see improvement with therapies. Is that something you're doing or not?
Yeah, no, we do. They do routinely, like every year, the patients they get like a CMR, so they just get CMRs like routinely, kind of every year. It's just like a practice, here, and that's one of the reasons why we're getting like a second dedicated scanner because our volumes they're just crazy. So I again we see that it's not that everybody gets repeat CMRs here, but we see that especially like the T2 signal goes down, and sometimes we might see like some residual LGE over there from this prior rejection episode.
Thank you very much. There's a comment from Fabiano. It says, congratulations, great presentation. I work in a hospital in Brazil that has started performing heart transplantations in 2025. Your presentation was very important to see your experience. So great to see you're inspiring people back in Brazil. And are you speaking at SCMR there?
Oh yeah, absolutely. I'm one of the organizing part of the organizing committee. I'm chairing the radiography expert session and also the co-chairing the the early career session as well. So I hope to see many of you there in Brazil, in Rio. And definitely, if you take a look at the forecast for Rio's weather for the next 2 weeks, it's going to be perfect, completely opposite from here. So even if you're not an imager, if you want to hang out in Rio, and escape from the winter storm that we're getting, that's a great place to be.
Thank you very much. We can end up with the advertisement of your lecture in Brazil. Thank you much for your time, and we'll be in touch.
Yeah, thank you.